I'd like to welcome everyone to today's AHRQ web conference on effective design and use of patient portals and their impact on patient-centered care. Although a few people are still logging in, we're going to go ahead and get started on time. My name is Chris Dimick. I'll be moderating this webinar. I currently serve as the Director of the Health IT Division in AHRQ Center for Evidence and Practice Improvement. You should now be viewing the slide depicting the agenda for today's webinar. Please note that we're recording this webinar, and the recording will be available via the AHRQ Health IT YouTube channel in a couple of weeks. Copies of the PowerPoint slides were emailed to each of you earlier this morning and were also available for download as you logged in today. We'll also be sending the slides to participants via email following the webinar, along with instructions for obtaining continuing education credits. Before we get started, I wanted to take a moment to remind everyone about why AHRQ sponsors these webinars and how this work is related to AHRQ's mission. As a research agency within the Department of Health and Human Services, AHRQ's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work within the department and with other partners to make sure the evidence is understood and used. AHRQ works to accomplish this mission through a diverse body of work carried out by its research portfolios and offices. This work includes investing in research, generating materials, and providing training opportunities, such as this webinar, that can help to foster diffusion of research findings to the agency's key stakeholder groups and to the public. The Health IT portfolio at AHRQ has a long history of supporting research that seeks to answer some fundamental questions related to health IT, including how health IT can be leveraged to enhance patients' experience and engagement in healthcare to affect better outcomes. Today's presentations will focus on the design and use of patient portals among varied populations and settings and their impact on patient engagement, diabetes self-management, and healthcare quality. We're pleased to have three esteemed AHRQ-funded researchers with us today. They are Dr. Ruth Masterson-Kleber, Associate Research Scientist at Columbia University, Dr. Courtney Lyles, Assistant Professor in the University of California, San Francisco Division of General Internal Medicine at Zuckerberg San Francisco General Hospital and the UCSF Center for Vulnerable Populations, and Dr. Jessica Anker, Associate Professor in the Department of Healthcare Policy and Research at Weill Cornell Medical College in New York City. This webinar event is accredited by Professional Education Services Group, and for those of you who are interested in receiving continuing education credit for participating today, information about how to claim your credit will be presented at the end of the presentations. It will also be emailed to you after this webinar. I also need to note that for purposes of accreditation, no one connected with this webinar has any financial interest to disclose. Lastly, please note that no commercial support was received for the development of this learning activity. Just a brief note about questions. We've reserved time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions for the presenters using the Q&A panel located on the right of the PowerPoint slides. As a reminder, participants are in listen-only mode, so to ask questions, you'll need to use the Q&A panel. Here are the learning objectives for today's webinar. At the conclusion of this activity, participants will be able to describe the impacts of an inpatient portal on patient engagement and satisfaction. Participants should also be able to identify features that make it both easier and harder for patients to use patient portals and ways to make patient portals more responsive to patient needs. To set the stage for our discussion today, Dr. Courtney Lyles will spend a few minutes talking about the expansion of online patient portals in the United States. She will share her specific research with us a little later on during the webinar. As noted earlier, Dr. Lyles is an assistant professor at UCSF. Her research there focuses on harnessing health information technology to improve patient-provider communication for chronic disease self-management to ultimately reduce disparities in health and healthcare outcomes. She's currently on a Career Development Award from AHRQ to engage patients in using online patient portals for healthcare management, including leveraging user-centered design and implementation science principles to create and spread technologies that are relevant for diverse patient populations. And now it's my pleasure to turn the control ball over to Dr. Lyles. Courtney?
Hello, everyone. Thank you for having me. I just thought we would spend a couple of minutes just to make sure we're all on the same page about portals before we each present about our work. So as you all are probably pretty aware, when we think about patient-facing technology in healthcare, I like to think of it on a spectrum from how integrated it is with the healthcare system directly. And portals that are tied to electronic health records are obviously on the far right of this spectrum. They're very integrated and they're feeding information directly from the healthcare system to patients, which makes them a little bit different than some of the other digital technologies like apps and connected devices, which sometimes are not integrated into healthcare settings. And when we use the word patient portal, the functionality that each system decides to turn on within their own healthcare setting varies somewhat, but it includes a variety of things such as viewing information like visit summaries, immunizations and allergies, and lab test results, as well as some more active features such as sending messages back and forth with providers or making appointments requesting refills. So different systems have turned on different features, but all of these functionalities are broadly considered patient portal access. And the screenshot here just shows sort of what the landing page looks like for the patient portal that I work on in my system. And then I wanted to show also what one of the features looks like, just to, again, hammer home the point of how integrated this is with the healthcare system. This is a test result for a fasting glucose test. And so the point here is just to show that it's feeding in the direct information from the electronic health record for patients to view that information, including all of their relevant details at the top, the type of test it was, and then all of the information about the value of the test and the reference ranges, and a summarized result at the bottom. And this is something that the patient might see when they log in and click on the lab results tab. The other thing that's important to think about is obviously the policy context for why we're all talking about portals. With the passage of health reform and the ACA and the HITECH Acts, there's been over $30 billion to date invested in something called the Meaningful Use Program, which has really rapidly increased the number of electronic health records and, by extension, portal websites offered in the United States. From a healthcare perspective, I would say this is a pretty steep adoption curve for our system since we're not so quick to adopt technology in a systematic way. And while these numbers are a little bit old, just to give you a sense of the vast majority are now offering electronic healthcare systems, and because the Meaningful Use Program had specific metrics for portal use, so for patients accessing the data within the EHR, the portal access is a little harder to gauge at a national level, but is likely over half of systems who have electronic health records are now offering some portal functionality within their system, so a pretty widespread technology. And then another important fact to think about is that portals are extremely patient-centered. When you look at national survey data of what patients want from their healthcare system, they both rank online communication tools and online tools for managing healthcare tasks like refills and test results fairly high. A majority want most of these tools. And so from a system standpoint, it's really a patient-centered and client strategy to offer these systems to patients, even despite the policy incentives as well. So in summary, just putting that all together, I think that when we think about the policy context and the types of functionalities that we're offering, there are a variety of reasons why we're also studying them in depth. First off, we're trying to move communication outside of the clinic with portals. We're touching patients and communicating with them outside of the walls of the clinic and closer to their everyday life. That's particularly important for those that have things to manage and need support outside of their office visits. There is some evidence that patients who use these websites have better health outcomes, which I think we'll talk a little bit about in the course of our presentations. They're very integrated into healthcare, like I've already said, and so when we think about merging in other patient-reported data, like information from apps or devices or other things, We would obviously think about portals being a primary way in which we would push that information from patients directly back into the EHR in a two-way setup. And then lastly, from a policy standpoint, it's really probably the first health technology that we've offered to diverse patient populations across a vast majority of healthcare systems in the United States. And so from a spread and implementation space, it's particularly important to think about that as we move forward.
Thanks very much for that introduction, Dr. Lyles. With this context in mind, let's move to our next presenter. Dr. Ruth Masterson-Creever is an associate research scientist at Columbia University. Using her training in epidemiology, biomedical informatics, and nursing, she conducts research focused on improving patient engagement, self-care, and patient-oriented and clinical outcomes for underserved patients with cardiac conditions. She's currently funded on a Pathway to Independence Award from the National Institutes of Nursing Research to support patients with heart failure in better symptom monitoring and self-care using a mobile health application. She's also collaborating with Dr. David Vaudry on an AHRQ grant to actively engage hospitalized patients using an acute care patient portal. And now I'd like to turn the control over to Dr. Masterson-Creever. Ruth?
Thanks so much, Chris, for that introduction. So today we're going to be talking a little bit about assessing the impact of an acute care patient portal on patient engagement and satisfaction with care. The learning objectives for today are to understand why we implemented this portal in the acute care setting, and then to describe methods for assessing its impact. I'm going to show you the portal, or some screenshots from the portal, and then we can discuss some lessons learned. So while patient engagement has been the focus in the outpatient settings, strategies to engage hospitalized patients in their care have not been as well studied. So we decided to implement our portal in the acute care setting because it's a high-impact setting that's been largely unexplored. Patients, especially those who are not in critical care, obviously, may also have more time while they're in the hospital to engage in interventions and devote more thought to their health. While hospitalized, patients also have a lot of information needs, which can be addressed with these health information technologies. While in the acute care setting, I think we can all agree that we really want patients to be able to be actively engaged and activated in their health. And as Courtney said too, patients who are better informed also have higher satisfaction and better health outcomes. That said, there is still no single definition of patient engagement, and nor is there a universally agreed upon tool for measuring this concept. So in this presentation, by patient engagement, I'm really referring to a construct that includes self-efficacy, health behaviors, and knowledge. Because knowledge really influences decision-making. And patient engagement has been heralded as a blockbuster drug in the 21st century by Health Affairs and other mainstream media, including the New York Times. As such, engaging patients has been the focus of many public and private sector initiatives and programs. Patients having access to the acute care portal can also support patient safety. We have 1 million free fact checkers. We just need to figure out the technology and the policies to help them engage in supporting patient safety. So now I'm going to delve into some of the details of the AHRQ-funded R01, that's a pragmatic randomized control trial. The primary outcome of this study is patient engagement, and this is measured by the Patient Activation Measure, or the PAM. The PAM is a 13-item self-reported measure designed to assess patients' knowledge, skills, and confidence in managing their health. PAM scores are categorized into 4 distinct levels of activation: disengaged and overwhelmed. The second one is becoming aware but still struggling. Third is taking action, and the fourth is maintaining behaviors and pushing further. Before implementing this, our study team validated the PAM in an inpatient sample. Patient satisfaction and usefulness in the study is being measured by the 26-item telemedicine satisfaction and usefulness questionnaire. In this questionnaire, 21 items focus on perceived satisfaction and 5 focus on usefulness. So we are enrolling 426 patients from medical and surgical cardiac units. There's 3 arms to this trial. The first arm is usual care. The second arm, patients get a tablet computer with general health links. And in the third arm, this is our intervention arm, and patients receive the tablet computer along with inpatient portal. And this is the arm that we hypothesize will see the largest improvement in engagement and satisfaction. So currently enrollment is ongoing. We've recruited 356 participants to date. And as you can see, the demographics of the participants who are currently enrolled are representative of our urban academic medical center in New York City. So now I'm going to walk you through the acute care portal so you can get an idea about the specific features that are available to the patients. So first we log in, and this is the home screen where patients can view the care team in real time. They also have access to care plan updates in the live feed to the right here, which reports new medications, labs, tests ordered, as well as all results. This is a really important feature that keeps patients up to date, and this is updated every 15 minutes. Here's a status page. Here, patients can look at the diet that's currently ordered for them. They can look at their weights and trends over time, tests ordered, and all the results, as well as vital signs. So for instance, if we click tests ordered, we get to see all a patient's test results. We can also see historical trends in any of their lab values. And here's an example of what patients will see on their vital signs. They can either see their vital signs as a list, or they can see a graphical representation of their blood pressure over time, or any of their vital signs over time. Here's an example of a medication tab. When patients click here, they can see all their active medications. And we've also collaborated with a fantastic pharmacy team who has created videos for the most common medications prescribed to patients across the hospital. Here, all these videos are tailored to patients with low health literacy. And this shows them typical what the indications for the medications are, as well as expected side effects and what to do about them. On this tab, patients are able to write in questions into the notepad they may have for their providers. That information gets pushed to the handoff tab in the electronic health record for their provider. And another really important feature that we have to really service the patients in our community is the ability to be able to toggle back and forth between English and Spanish. One of the newest features of the portal is access to the clinical notes. And here patients can get access to not just their current notes, but in notes from previous hospitalizations as well. And as you can see, these are patients' notes in real time. And what we did here was we employed a mixed method approach, including patient surveys, system usage logs, and qualitative interviews to describe patient perspectives on receiving their clinical notes. I've included a few illustrative quotes on each of these slides to support the themes that we've identified. Not surprisingly, we found that notes were really useful for patients. Patients spoke of reading clinical notes as an informational supplement to the verbal communications they have with their clinicians. These notes informed questions that they had for their providers and gave patients greater clarity that was not as rushed as they had in the interactions that occur in rounds or in other one-on-one interactions. Patients also viewed the notes as objective indicators of both their health condition and their progress while in the hospital. They also expressed a sense of ownership over their data and wanted access, independent even of their plans to read or to use it. We also found that the notes really improved patient comprehension. Patients spoke about the notes as truth tellers that improved their insight about their progress and their condition. One patient requested for a family meeting after reading the notes because she realized that her condition was far more serious than she had thought. After the family meeting, palliative care became involved and was able to arrange for the patient's discharge to home hospice. The notes helped to get the patient and the family on the same page as the healthcare team. And the notes also gave the family a much more realistic perspective on the patient's disease severity. So some of the concerns that many people have expressed about sharing notes, inpatient notes with patients, has been patients' emotional response. But interestingly, in this study, no patients reported more anxiety after reading the notes. And actually, being able to read the notes increased trust that patients had in their providers and appreciation for the work that they do. Some patients also reported some specific health behavior changes, including taking a nutritional supplement after reading the nutrition notes, and another reported taking antihypertensive medications after viewing vital signs and realizing that his blood pressure wasn't quite as under control as we thought it was. Based on the system usage data, participants navigated to the clinical notes feature most frequently and for longer durations than any other feature, and this was followed by lab tests and then medications. The barriers and benefits of the note sharing still require further exploration before we consider widespread adoption throughout the entire portal. So through implementing this acute care portal, we've learned a number of lessons that I'd like to share. Firstly, patient-provider communication is arguably the most valuable function of the acute care portals. It's really what distinguishes the portals from other healthcare applications. However, implementing patient-provider messaging requires explicit attention to the clinical workflow integration. Within our portal, the messaging for providers was pushed to a handoff tab where providers could view the patient questions. Secondly, patient education is really important. And while the portal may contain explicit educational features, in our case, like the YouTube videos and the info buttons in the medication tab, actually having patients have access to their own data within the portal was really contributed a lot to patients' education. And actually, in our case, patients didn't use the info buttons as much as we expected that they would. This is partially because patients perceive that info buttons provide similar, sometimes even less information than simply Googling the term. A high-value portal also includes the care plan for patients, and this is especially important in the acute care setting. Patients want information on a daily schedule or agenda, including upcoming procedures, lab tests or imaging, upcoming medication dosages, consultations or therapy sessions, rounding times, upcoming family meetings, and meal times. In our experience, patients express the most interest in upcoming procedures, lab tests, and then consultations. Through our study, we also found that patients want full access to their clinical data. We believe full transparency is ideal, with a few caveats. Hospitals should avoid presenting information which is uncertain, including working diagnoses. And the timing of information release is critical to consider, especially delaying the release of highly sensitive lab and test results. Patient reported several incidents where having access to the portal improved patient safety. And this is why having access to patients' medication lists and allergies is really important for patients. A few patients noted medication errors and were able to catch them before the medications were administered. For instance, one woman noticed that prednisone had fallen off her medication list. She was able to quickly show the nurse, who agreed, and within a few minutes, prednisone was back on the medication list and the nurse could administer the pill. For our acute care portal, we've also been asked if we can give caregivers access to the portal, especially remote access, so caregivers can stay on top of what's happening in the hospital, even if they have other responsibilities at home or work that prohibit them from being at the hospital all the time. We also had patients who wanted to use their own device rather than our tablet because using a second device felt redundant. Finally, patients and caregivers both appreciate information on amenities, such as the menu from the hospital cafeteria and visiting hours. Strong stakeholder buy-in was really, really important for the design, development, and then implementation, both from hospital administrators as well as the healthcare team. And that's critically important to think about when you're thinking about adopting and implementing an acute care portal. Secondly, a hospital culture of innovation helps the adoption of any new technology, but especially one that needs to be as integrated as an acute care portal. Third, it's really helpful if the portal is sanctioned by healthcare providers and that they show an interest in supporting patients to use it. And finally, portals are never a replacement for in-person communication. rather an opportunity to optimize it. This is my contact details, and feel free to email me if you have any questions, as well as bringing up any questions in the question and answer time. Thank you.
Thanks very much, Ruth, for sharing your interesting work with us. Just a reminder, Ruth also just mentioned it, but for those of you with questions, please submit them via the Q&A panel. Some of you already have done that. We'll come back to those questions at the end of all the presentations today. Now, let's move on to our next presentation from Dr. Jessica Anker. Dr. Anker is an associate professor in the Department of Healthcare Policy and Research at Weill Cornell Medical College in New York City. She conducts research on how to optimize health information technology to promote better decision-making by patients and clinicians. Dr. Anker?
Thanks so much, and thanks for having me. The work that I'm going to be presenting today is also about patient portals, but it's a little bit of a different context. We'll be talking about portals used in the outpatient setting, and particularly I'm going to be talking about a portal used for primary care patients in a safety net setting. So to set the stage for this, I think we all agree, as Ruth pointed out, that what we'd like to see with portals is this sort of virtuous cycle where the patient has access to better information, they make better decisions, they might in fact provide better information to the physician in the hospital, which then presents that back to the patient, and we get this positive cycle of better education, better patient decisions, and better clinician decisions. The potential problem here, I'm going to say but, this requires getting the cycle going by reaching all of the different patients who need it. The first problem that we need to think about is the problem that the patients in the greatest need have to have access. If it turns out that the patients in the greatest need are also less affluent patients who don't have computer access, that could be a real problem here. Second problem is that the patients in the greatest need of help have to understand what it is that they see. Ruth showed some screenshots, and as did Courtney, showed some screenshots of what's available in a patient portal, and by definition, it's all full of medical jargon. There's all sorts of lengthy words in there, and when you log on for the first time as a patient, it's very likely you're going to see some words that you don't understand. If it turns out, in fact, that least educated patients are less likely to understand this information, then that's potentially a problem as well, that we're having, potentially have differential effects depending on these patient characteristics. If we don't succeed in reaching the patients in the greatest need, and if it turns out that only relatively well-educated patients with access to portals can actually understand them and apply that information, we could be seeing a worsening of health disparities. So the person at the top with a little dollar sign at the computer is someone who's relatively well off. They access their information, they're able to apply it, and their health indicators go up over time. But potentially the person on the bottom who has neither resources nor education could potentially flatten out or even get worse over time. So that's the situation that I've been concerned about, and what I'd like to show here is some ways that we've been exploring for addressing these issues. The work here is done in collaboration with the Institute for Family Health. This is a community health center, a federally qualified health center. They receive federal and state funds to provide primary care to any comers. They have a sliding scale, so if you're uninsured, you can pay what you can. But they also take all forms of both private and public insurance. The Institute for Family Health is quite large here in New York City. They have 18 sites in the city. They also have expanded to smaller towns north of the city, so more of a little bit of a small town rural setting. Despite the fact that they're a community health center, they're relatively early adopters of health information technology. They've used the EPIC electronic health record since about 2003, and they deployed the electronic patient portal called MyChart in 2007, so they were on the early adopter side of this curve. They deployed their Spanish language version in 2011. Not surprisingly, their patient population averages relatively low income. There's a very large proportion of Spanish speakers. And since they're a family practice, the patients are relatively young, tend to be young women with and without families. So we do see a little bit of a young side on the patient demographics. So what I'll be talking about here today are two projects. One of them was to try to reduce disparities in access to the information technology, and the second one is to add value by adding information resources to that portal. The first one came about because we took a look at in 2010 at who was using the electronic patient portal. Here's a little snapshot of the patient demographics. There were about almost 75,000 patients in the pool at that time. Only 44% white, only 39% privately insured, and 23% uninsured. About the same proportion were Medicaid. And you can see that down at the bottom of that table, only 16% of them had gotten an access code to let them set up a portal account, and only 10% had actually activated the portal. So the question arose, who was it who was using the portal, who was not using the portal, and why? We initially, sorry, I'm going to go back here for a second. The initial hypothesis was that patients with less education might be less likely to be interested in the portal, and that patients with less resources might be less likely to have computer access. However, when we started delving into the data a little bit more deeply, what we found was that the disparities began really, honestly, at the physician and the nurse level. In order for a patient to establish an account, the nurse or doctor had to set up the account for them. So when we looked at the odds ratios for the different demographic variables, what we found was that women were more likely to get this portal offer than men. Older patients were less likely to get it as they got older. Whites were quite a bit more likely to get this offer than the blacks were. And English speakers and privately insured patients were quite a bit more likely than other patients to receive this portal offer. And then finally, people with chronic conditions, with each additional chronic condition, you are more likely to receive this portal access offer. I think you can see that some of those seem clinically justifiable, and some of them seem a little questionable. So the justifiable ones probably are female sex and chronic conditions. As I mentioned, a lot of young women are taking care of families. They are, in fact, using healthcare more frequently than men of the same age. And so it is somewhat not surprising that women would be more likely to receive an offer to use the portal. Similarly, if you've got things wrong with you, you're more likely to be interested in the portal. We also took a look at, among the subset of people who received that code, did they ever activate it? Did they ever actually set up their account? Again, women were quite likely to set up their account. But look at the odds ratio for age. What we found was that older people were actually more likely to set up their account. If they had received an offer from their physician, they were more likely than younger people to actually establish that portal account. We do see the expected disparities in race and preferred language and private insurance, and the chronic condition is still in the expected direction. Now, this is just data. We don't know necessarily why this data occurred, but the institutions said that they were concerned that this meant that there was some sort of disparity in the way the portal accounts were being set up, and that maybe they could remedy this at the institutional level. Because what we see is that the disparity originated with who received the offer to set up a patient portal. So, in other words, in the early days of this project, the organization had an opt-in policy. You, as a patient, you can have a portal account if you ask for one or if your doctor asks for one for you. They switched this to an opt-out policy, which is we are setting up patient portal accounts for all of our patients unless you specifically say you don't want one. So they did this through automatic code generation at check-in. As soon as you walked in the door, the front desk checked whether you already had an account. If you didn't have one, they created one for you right there. They also got the medical assistants involved in helping people set things up, and they also recorded if people said no, they don't want one, then they actually recorded it so that they didn't keep irritating people who had said no. By changing this policy, we then did another study and took a look at how that changed the patient use of the portal. And what we see is that top line there that rises sharply from 39% to 96%, well, that's who got a patient portal offer from the institution, and you can see that within 4 years they were almost 100% successful in giving access to all of the patients. But the other very interesting curve that I'd like to draw your attention to is the dotted line. That's the second one down that rises more slowly from 20% to 32%. What that is telling us is that the number of patients who actually ended up using their portal, actually setting it up, also rose by quite a bit. Not as sharply as the offers, but still quite a bit. So just by changing that enrollment procedure, they also saw changes in usage, not just in offers. In 2011, as I mentioned, we saw fairly large disparities on the basis of race, Hispanic ethnicity, and insurance status. By 2014, when we reran very similar analyses, the race-based difference completely disappeared in who was using the portal. Blacks were just as likely as whites to use the portal. The difference between Hispanics who felt fluent in English as opposed and non-Hispanics completely disappeared. Again, they became just as likely to use the patient portal. We did still see some residual lower access rates for the subset of Latino patients who said that they felt much more comfortable in Spanish than in English, and we still saw differences on the basis of insurance status. But overall, the disparities narrowed drastically. So the next thing we did was take a look at national trends and see, well, the hypothesis was, well, nationally, there are more and more people likely to use the Internet, so maybe that's accounting for the findings we're finding. But we don't think that is, because in 2011, when we took a look at the data nationally, this is data from the Pew, Internet use among blacks was less frequent than Internet use among whites by about 18 percentage points. If you look carefully at that graph in the lower right-hand corner, you'll see that in 2014, use of the Internet rose in all ethnic groups. However, blacks were still 18 percentage points behind whites on average. So nationally, we don't see a narrowing between black and white use of the Internet, but we did see quite a bit of narrowing in our data, and again, similar findings for Latino patients as well. So in other words, we don't think this is just because of national trends. We actually think it's because of our policy changes. And replacing this sort of opt-in policy that requires initiative on the part of either the physician or the patient with an opt-out policy not only increased enrollment but also increased usage and reduced disparities. There were still things that we could not affect. There's still externalities in patient resources that we weren't able to change, but we could change some things. I'll spend less time on the second project, but I just wanted to give you a flavor of that one as well. This project was, if we've got this portal, how can we make it more useful for patients? This technology was developed by the Institute for Family Health with some funding from the National Library of Medicine and some in-kind support from EPIC, the AHRQ company. And this resource helps patients see education materials about their conditions. So in the top left there, the EHR has an ICD-9 or 10 code that tells you that the patient's got streptococcal sore throat. By the time it gets to the portal, it's been automatically replaced with a somewhat more patient-friendly term. Strep throat is more familiar. This patient-friendly term is automatically turned into a hyperlink, which hyperlinks it directly to the National Library of Medicine's patient-friendly medical encyclopedia, Medline Plus. What this does then is, what this means is that the patient doesn't have to know how to use search terms. They can just click the hyperlink and they can get right to this medical encyclopedia that's written in about the 8th grade reading level. So just as with the previous study, our first question was who's using it? And at this point, we found that quite a lot of the portal users had tried these hyperlinks, 42% of them. And that's 10% of all of the Institute for Family Health patients. So a lot of people had clicked on one or more of those hyperlinks. When the next question is, are there disparities in who's using it? And we had originally suspected that we might see some of the same kind of disparities where more educated patients maybe were more likely to follow these links. Unfortunately, we don't have a good measure of education or of literacy or even of patient activation because we're limited to what data we've got available in the EHR. When we took a look at this, however, we saw some unexpected findings. We saw that Black patients were more likely to use this medical encyclopedia than white patients were. We saw that Latino patients were more likely than non-Latinos, at least if they were English-speaking and felt comfortable in English. And we found that residents of our poorest borough in New York City were more likely than residents of other places to use this. This was somewhat unexpected and actually rather exciting because even though we don't have measures of health literacy, we do know that these demographic indicators are associated with poor health literacy on average. And so maybe we are actually doing a good job of providing information resources to people with lower literacy who need more assistance in interpreting this medical jargon in their patient portal. Quick little glimpse of some of the things that people were clicking on. On the x-axis, we see the number of patients with the diagnosis, and on the y-axis, is the number of times that diagnosis was clicked. So you can see that female infertility was clicked quite often. Endometriosis. These are, as I said, this is a population that skews female, so quite a few people were clicking on those. We saw anything related to cancer got clicked on quite a bit. Anything related to childhood diseases also got clicked quite a bit. Some of the chronic conditions like diabetes were very unpopular. People did not particularly click on those. We figured that they had already received all the information that they wanted from their providers and that these are chronic conditions and they didn't perhaps feel particularly motivated to learn more, whereas acute conditions did tend to attract a lot of clicks. Lessons learned from this is that we got very high usage of this plain language encyclopedia. We did see that it was appropriately used most by people with more medical conditions and more visits. And somewhat unexpectedly, we saw it was disproportionately used by members of various demographic groups where the prevalence of low health literacy is known to be high. So we are hopeful that that means that this resource is, in fact, providing particular value to those patients who have less familiarity with medical vocabulary and more in need of some educational resource to understand what it is they are seeing and potentially more likely to then apply it to their own health decisions. The final point I want to make is that these issues of computer literacy, patient activation, health literacy, and numeracy are often thought of as a patient-level issues, that we would measure these at the patient level. But what we found was changes when we changed the system, we overcame some barriers that had previously been suspected to be related to these individual level barriers. So I'm optimistic that we can find other ways of making our healthcare system more patient-oriented and helping people compensate for individual variations in things like literacy and things like health literacy. This was funded by my Career Development Award, and as I mentioned, that there's a little bit of additional funding here from the National Library of Medicine and some in-kind support from EPIC. And with that, I'd like to thank you very much for joining our webinar today, and I'll turn this back over to Chris.
Thank you very much, Jessica. As a reminder, please submit any questions you have for Dr. Anker using the Q&A panel, and we'll come back to them after our final presentation, which is being led by Dr. Lyles, who we introduced earlier. Dr. Lyles?
Thank you. So my last few slides here are going to dovetail pretty well with what Jessica just presented, especially about thinking about usability of portals and safety net healthcare systems. Before I get into the safety net, though, I just wanted to give a sense of what portal uptake looks among some early adopters who are non-safety net, In case you haven't seen data like this coming out of Kaiser Permanente, Northern California, where I also spent some time doing research, in settings like this, they have about almost 3/4 of their patient population registered for portal access. And you can see here that the two most used features are lab results and secure messaging, over 15 million lab result views, and they're on track to have more virtual encounters via email and or telephone visits and in-person encounters in the next few years. So pretty substantial uptake that looks pretty different than the numbers even that Jessica showed. I love that you showed those among what the uptake is in safety net settings. And when you drill down a little bit more, I just wanted to build on what she said about differences by race ethnicity in using portal websites. There's been multiple studies across multiple integrated healthcare delivery systems. This is just two really quick bar graphs from both Kaiser Northern California and Group Health, which is now a Kaiser site in the Pacific Northwest, showing that racial ethnic minority patients, particularly African American and Latinos, are significantly less likely to be portal users even in these systems. And I just wanted to make the second point that we've adjusted for multiple covariates in these models, including a lot of health characteristics and health status information and demographics, which are obviously related to portal use, but also whether or not the participants use the internet in their everyday life, and how much the provider is recommending that they use the portal, and how much the provider is using the portal as a part of their ongoing panel management. And just to give you a sense that these racial differences persist even when you adjust for all of those factors. So there's some other things happening here. So moving from that space into the safety net space, I work at San Francisco General Hospital, which is part of the San Francisco Health Network. And we are about more than a decade behind where Kaiser was in launching their portal, in the sense that we just went live with our outpatient EHR in 2013 and launched our portal in 2015. We are a very racially, ethnically diverse patient population. About 3/4 of our patient population is Medicaid or uninsured. And we also have very high levels of linguistic diversity. About 45% of San Francisco households speak languages other than English at home. So as part of my career development award, I spent a lot of time thinking about in-depth qualitative work to hopefully answer some questions about barriers and facilitators to use among our patient population. And we did 2 in-depth studies right before and then right after we launched our portal with patients in our setting. We had to limit it to English speakers because we're only offering our portal in English at the time, and our vendor actually only supports it in English at this time as well. And we also looked at patients with chronic healthcare conditions because, as we've seen previously, these patients have the most need and are the most engaged in using portal for managing their healthcare. The in-depth interviews that we conducted were open-ended before the portal was launched, just to talk about technology use and portal use. And then the second study was an observational study called a Think Aloud study, where we actually videotaped our patients interacting with the portal interface to understand what they could and couldn't do. So the in-depth interviews, I'll just quickly go over that. There was high interest among the participants in our in-depth interviews for using the portal. Sort of mirrored those national data I showed earlier, just to underscore the point that many patients in our setting have interest in doing the types of features that you're able to do on a portal website, in particular accessing their lab results, their appointment information, and their visit summaries. And because of that, the benefits for using the portal were in line with what you might expect when you talk to patients about the types of things you might be able to do online. This patient said it really well. And if I had a consultation with my pharmacist and they're telling me of side effects to watch out with some of my medications I'm taking, and I have one of those side effects, I might discuss it with the doctor on email, and that would be really helpful. But the types of barriers that come up in our setting might look a little different than the general population. There was definitely barriers with more sophisticated tasks, I would call them, like creating secure passwords that might be associated with setting up a portal account. This patient put it as, you have so many words and letters and characters. How do you distinguish that? I mean, you say characters, are they letters? And then similarly with the content piece that Jessica started, there was some concern that they wouldn't understand all the information presented to them on the portal. This person said, I would probably log on to see a blood test result, but I wouldn't really, unless somebody explained it, I wouldn't know what I was looking at. And then lastly, we also included a few caregivers in our study because we think that's a pretty large population of individuals who will likely be involved in portal use to take care of the healthcare management of a loved one. And this character talked about language barriers in particular. And he said, is there any other options like other languages that you can change the message to? And if I teach my dad how to go online and he can look up for himself, can he click a button that's not hard for him to change it, let's say to Vietnamese? And I just wanted to make the point here that, well, first of all, Vietnamese is not a language that any vendor that I know of can support currently. And so we probably have a lot of room just to work on that. And then secondly, I would like to make the point that even if we have navigation that's been able to turn on in different languages on portals, which are available in several vendors, the actual EHR data is still in English for all patients. So the medical information pushed through is not going to be translated, at least at this current time. So the second study that I'll present really briefly was that observational think aloud approach. We videotaped patients as they interacted with the actual portal interface, the test account on our portal interface, and we asked them to complete all 5 tasks that were available on our portal, from logging on and reviewing information to looking at the information on online dictionary that's available in our portal. And we asked the participant to try each task twice independently before we would step in and help them to get a sense of how many of them could actually complete the task independently. So the types of things we coded in these analyses were how long it took them to do the task, how many times they tried, and whether or not someone did step in to help them. We also more qualitatively coded the types of barriers that emerged when they could not complete the task. And we had things that were computer related and things that were more content related. The first 2 are computer related, and we divided them actually into 2 categories because we saw a lot of things that we called novice computer barriers, which I would describe as barriers in which people were less familiar with using computers overall, that they could search things, but they didn't necessarily know how to make capital letters or characters on the keyboard, things like that. Versus distinguishing that from routine types of computer barriers, which were making typos when typing or having to click around for a while before you find the section that you're looking for, which even people who are sophisticated might have some challenges with in looking at a brand new website. And then we had both reading and writing kinds of content barriers, as well as we separated out how many specific health or medical content barriers there were. And lastly, I'll just present the information stratified on their self-reported health literacy status because it became pretty influential in our analysis. We had a validated self-assessment of health literacy about how confident they were in filling out the medical forms on their own. This is a sample from the Think Alouds, slightly more of patients with limited health literacy than adequate health literacy shown in those 2 columns. But an average age in the middle-aged, which is on par with our patient population with chronic illnesses, and the majority female and fairly racially, ethnically diverse. And then the last 2 I just wanted to highlight, this is where the differences by health literacy started to come out, which is that we had a high number of individuals saying they had a high interest in using the internet to manage their health and use the internet at least daily, weekly, if not daily. But that it was pretty different even by this initial assessment. You can see that those with limited health literacy had lower interest and lower frequency of internet use overall. And then when we started to look at our outcomes, these health literacy differences persisted. Those with limited health literacy were completing only about 1.3 tasks without assistance compared to over 4 tasks among those with adequate health literacy. And those with limited health literacy also had substantially more novice types of computer barriers that I discussed a second ago. This last slide just shows the same types of proportion of patients who needed assistance to complete the tasks, with the blue bars showing limited health literacy and the orange bars showing adequate health literacy, just to give you a sense that those with limited health literacy had more challenges throughout all of the tasks. But I would like to point out here that almost all of the patients had barriers at the beginning of the task and getting in and getting oriented to find the first information that they were asked to find, suggesting that they all had some challenges getting oriented. So these two formative studies, I would say, have two main takeaways for me. The first is that there is a lot of interest among our patient population in using these systems, and there are a substantial number of our patients who could access the information, especially after they were oriented to the website. However, the more vulnerable of our patient population probably need extra one-on-one assistance or coaching to be able to actually use this website effectively, and that limited health literacy in particular seem to be a proxy for some digital literacy skills among a small sample, and might be interesting to think about moving forward of how to offer additional support to patients. So what are we doing with this information? Well, we thought a lot about doing interventions and things through our portal, which we're working on, but a first step from these findings seemed to be that we needed to develop training materials for our patient population, and so we spent a couple of years designing online video-based tutorials to access the website. And these are short videos explaining both the premise of why you might want to use a website like this, as well as brief refreshers about using every single feature of the portal, so that each patient could watch, less than a minute-long video about resetting their password or finding their lab results, et cetera, in case they needed more support and help in doing that task. And we don't have the full data yet, but we rolled out these trainings in a small research study last year, and we followed patients up for 6 months to see if the training actually influenced whether or not they used the portal in the 6 months post-training. This is just the baseline characteristics of the sample that we trained. We trained 93 patients. About half of them watched the videos with us in person and spent a lot of time going over the materials together, and the other half got the link to all the videos and information about the portal, but were sent home to watch the videos on their own. The patient population looked relatively similar to the patient population that I just showed you in our other studies. A high number of chronic conditions, a little over a majority having limited health literacy. This is a patient population with relatively low medication adherence and middling self-efficacy for managing their chronic illness. But again, some interest in using the internet and some relatively high rates of using the internet on an everyday basis. So it reflects what I just showed you, but the interesting fact, even when looking at the baseline data, is still a third of these patients without ever seeing the portal website felt like they didn't have enough skills to be able to use it. Many of them ended up watching the videos, even though we sent many of them home, and then watching the videos on their own to try to be able to learn how to use these platforms in more depth. In terms of conclusions and next steps, I think one of the important things that we've learned here is the partnerships with community groups and libraries and thinking about digital literacy more holistically has been a really important component of this project. We've created these videos in partnership with our medical library on campus at the hospital, who's obviously a natural partner for expanding the digital literacy capacity of our patient population, but it's probably underused in our setting for that purpose. And then there's a number of other community groups throughout the San Francisco Bay Area who actually work on digital literacy promotion, and so we've been expanding our work to refer patients and to build capacity among those organizations, because we often don't have space or time within the clinical setting to actually provide these services. We also learned through this, obviously, like I just showed, that just because patients say that they're currently using the internet, it doesn't really equal a proficiency that's perhaps sophisticated enough to use the existing portal interfaces that we're offering. And while I didn't talk about it, I would like to make the case that there are other issues that are related to portal use beyond skills, which is the main thing we focused on, which include broadband, Wi-Fi, and device ownership that still have some digital divide aspects to really overcome. And then in the longer term, I think there's a lot of work to partner with patients to co-design interfaces for maximum accessibility and relevance. I think central to that really should be literacy and language barriers throughout the entire system, portal systems that we develop. And that we have to think about both the functionality of the websites, which is really important, but also about the implementation strategy of how we're actually engaging our patient population, because both are really critical for more widespread and diverse uptake of these systems moving forward. Thanks a lot. Here's my email.
Thank you, Dr. Lyles, and a big thank you to all three of our presenters for their terrific presentations. This concludes the content portion of the webinar. Now we have a few minutes left for questions. One more reminder about questions. You can type them into the Q&A section of the WebEx portal. We have quite a few right now. We may not be able to get all of them answered, but we will answer them in writing and send the answers out to all attendees after the webinar. So with respect to an initial question here that I've seen several iterations of through the Q&A portion of the WebEx, we have several around how physicians feel about patient portals. For example, how do they feel about patient messaging? Are they allowed to bill for their time responding to questions? How do patient portals benefit physicians? And this is a question that any of our presenters can respond to, I think, so feel free. Maybe we can start with you, Courtney.
Sure. Yeah, I didn't present any of that data, but we do work on the provider and staff side a little bit as well. I would say that the systems, from my perspective, that I've done that have figured out messaging the best have been the integrated delivery systems, which are capitated for the payment of their patient population, meaning that one provider is responsible for an entire panel of patients, and for them, they're salaried, and it makes most sense to communicate with their patient through any format to help them stay healthy and to have them stay out of the hospital and prevent complications, et cetera. It gets more challenging when you think about it in a more fee-for-service kind of environment, and our system is actually mixed in that setting. And so I hear that concern. We did a little bit of provider surveying, and definitely that is one major concern of protected time to do this. And I do know anecdotally that places like Kaiser do give some protected time for emailing, but the volume of emails, it just keeps going up and up. And so it's an ongoing challenge that I think we need to continue to study.
Ruth or Jessica, did you want to respond to that?
In our acute care portal, patients were able to submit questions to providers, but it wasn't a two-way messaging system. And so, and actually we were very surprised that even though that functionality is present in the portal, very few patients actually utilize it. And so we're not exactly sure why. That could also just be a function of some older adults that were primarily in receiving care in these units, and that may not be the way that they are typically expected to interface with their providers. So when patients did ask questions, though, providers would address that the next time they went into the room.
And this is Jessica. I'll just add quickly that in the outpatient setting that I was working in the Federally Qualified Health Center, to deal with this, they created a triage approach for email messages from patients. They set a very firm expectation that every patient should get a response within 24 hours, which they're amazingly good at doing. I looked at the data recently. But the way they do this is that they do have a triage approach where the emails are screened and they either go to front desk for scheduling or to a medical assistant or nurse for some a basic question answering or to the doctor, and that's how they handle that. But anecdotally, I would agree with what Courtney pointed out earlier, is that the volume of messaging is going up. It's not explicitly reimbursed for, and I think that that's a problem. The Federally Qualified Health Center is a salaried organization there too, so there's no fee-for-service incentive on the part of the individual doctors, but there's still limited time.
Right. Interesting. Thank you very much. We have another question here about key strategies to take away to get more patient engagement in portals. So I think this is applicable to all of our panelists. Why don't we start with you this time, Ruth, on the inpatient setting. What's a key strategy that can get more patient engagement in your portal?
Great. Yeah, well, I think I did address that in some of the lessons learned, and so I think there's actually a number of different ways to be able to engage patients. But I do think that one of the important things is really having that support from the providers, and if they're asking patients, if they're using them, and if they express interest in patients being able to engage in their medical information and their clinical information that way, we found that patients really get a lot more excited about it as well. We also have a research assistant, though, because this is a study, who is able to support the patient with being able to get on the portal and to do that initial navigation together. And so I think having someone who is a specified person who can support the patient, especially with that initial navigation, is really important as well.
Thank you. Jessica or Courtney, would you like to comment on a key takeaway strategy for folks listening in on the webinar today?
I'll jump in. This is Jessica, and say I really appreciated the points that everyone made about adapting the technology to the needs of the patient. I think we are in a situation where the healthcare system is not necessarily optimized as a whole for the realities that patients face, whether it's language barriers, whether it's time and convenience, or whether it's health literacy issues. And so I think all of these issues of thinking about how we can meet what the patients need is going to be how we get from here to there, rather than trying to necessarily cherry pick the right patients that we want. So I think all these issues about increasing the usability of the portal are really important, increasing access to information resources so patients can learn. The training videos is a great idea. We did a little bit of work with some training sessions as well with patients, but we're not able to scale that up to reach the large number of patients who need it. I'd love to see more of that. But that is pretty time-intensive and resource-intensive to really get that up as a big program.
Yeah, I agree. I echo both of those points, which is the provider and staff engagement and referral and recommendation is a real critical piece. It's been shown in some of our previous work at Group Health how important that is for patients themselves being a user. And then secondly, I would echo that. But at the same time, there are going to be a lot of additional questions and needs that there's just not sufficient time within the visit to handle. And I think having a strategy, at least for managing those questions, even if you can't make a full-blown training program right off the bat, is pretty critical for making sure the uptake is diverse and not just the most engaged or healthy patients who might be the most likely to want to sign up first.
Thank you. And Ruth, we have a couple of specific questions for you. Which EHR vendor did you use for the acute care patient portal, or did you develop that application in-house?
The application was actually developed in-house.
Okay, great. Thank you. And another one for you. Did the clinician notes in your portal have hyperlinks for definitions of the medical terms? You saw that
and that's a great question. That was one of the things that the patients struggled the most with in terms of their clinical notes. Even though they didn't understand them, they still wanted to be able to have access to the notes. So it wasn't a deterrent in terms of wanting to still have access to them, but it was one of the things that made them harder to understand. But we are actually working on a program that would help to be able to explain some of those acronyms and some of the words that are harder for patients to understand.
And another question for your inpatient setting, what considerations were made with regard to patient tablets and infection control?
Yep, so between patients, all the tablets were wiped down with antiseptic wipes, and patients typically would have the tablet for the duration of their admission. So in that case, it was just staying with the patient, but when we would clean them very thoroughly between patients.
And in your inpatient setting, were there differences between Spanish versus English users? And did you capture literacy and educational demographics in your project?
Absolutely. We have a very detailed demographic information on all the patients and their technological literacy as well, health and technological literacy. So we we haven't analyzed the results yet, but all that information is collected, and when we publish the results of the study, we will certainly be looking at any differences. But the important thing is that the portal was accessible and is accessible to both English and Spanish speakers. Our research assistants are all bilingual, and the study is completely explained in both Spanish and English, and all questionnaires are done in both as well.
And just one more question about the acute care setting. Did you get much resistance from providers?
That's a great question. Prior to implementing the study, we actually did a clinician survey with 53 clinicians in the specific hospital that this was implemented in. And what we found was that most of the providers agreed or strongly agreed with having access to most aspects of the portal. The things that there was a subgroup of providers who did strongly disagree with giving patients access to consultation notes, progress notes, and procedure reports. However, after further, and we're still in conversations about this, and so currently, like I said, it's not all patients have. It's just patients that are enrolled in this subgroup of the study that have access to the clinical notes. So it's ongoing conversations.
Thank you. This next group of questions that's coming in has a lot to do with the actual review of medical record accuracy and completeness. There's a great quote that somebody sent in that said, Napoleon said, history is a set of lies agreed upon. Will patient review change that? And, with regard to medical record error rates for omissions, commissions, what do you think about patient corrections or interpretations of what's presented in the portal? So perhaps, Jessica, we can start with you this time.
That is such a great question. And if anyone's got some experience with the Open Notes project, I'd love to hear that. But let me tell you something that we were looking at in our data. Again, everything that I've presented is secondary analysis of the HR data. So there's advantages and disadvantages to that. And the disadvantages, I don't necessarily know why I'm seeing what I am seeing. But one thing that we did take a look at, because it was just the HR data, we don't know necessarily how accurate it is. But we did look at the problem list and whether it was being regularly updated by the provider. And we thought maybe that was potentially a proxy for something about how the provider was, their documentation completeness or how they were using EHR. And we thought that maybe they would be more likely to keep that up to date for patients who were using the portal, because the patient should be looking in there and potentially catching, if they potentially omissions, I would think, or commissions of conditions that were not accurate. And we did not actually see evidence of that. But I would love to try to drill down deeper, because I would strongly suspect that this would have some effect on the way physicians are documenting.
Would anyone else like to address that?
I don't have any specific data about that, unfortunately, but I think that's just an underlying assumption that the more patients have access to their information, the more information will be correct. I mean, the way I see it is even medication lists from the after-visit summary that are available in the portal are often have mistakes, and there isn't enough time always to do medication reconciliation, at least in the outpatient space. And so even that one example on an after-visit summary, I would imagine there are many things to double-check and to go over. And I see it not just for correcting information, but actually as an engagement tool itself, in the sense that the more patients are looking at that information, the more they're actually aware. And I think Ruth had some quotes that reflected this in her study. And so to me, it makes natural sense. And I think if there isn't literature out there, I'm guessing there will be soon about some of that specifically.
Thank you. Jessica, there's a specific question for you here. With regard to your work, are you planning on looking at whether the uptake in patient portal changes patient clinical outcomes?
Yes, good question, and yes, I am. When as I mentioned, I'm currently supported on my Career Development Award from AHRQ. when I wrote this award a number of years ago, when I applied for the grant, there really had been very few people who had done any of that sort of outcome type of work. And so I proposed that I would spend this coming 2017, 2018 doing that study. In the several years since I submitted the grant, and now I'm moving along in the grant, it turns out a lot of other people have started publishing that type of work, showing that under certain circumstances and with certain types of patients, you can, in fact, track portal use to better outcomes. So some of the messaging work coming, particularly out of Kaiser, has demonstrated some beneficial outcomes. So I've adjusted my plan slightly, and I'm going to I'm in fact just in the middle of data collection from the EHR for a study right now of looking at a patient upload function. So very recently, we've started allowing patients to upload their own hemoglobin A1C and, no, not hemoglobin, sorry, blood glucose for diabetic patients and blood pressure for patients who have hypertension who are self-monitoring. And we've got a relatively small cadre of people who are regularly uploading their data to their physician in advance of their next medical appointment. So I think this is a really interesting group. It's a relatively new functionality, and this is an interesting group of people to see if we suspect that should help them communicate better with their physician and better manage their own health, but no one's demonstrated that yet. So we are just starting to take a look at that.
Thank you. And Jessica, there's also a question here about the opt-out policy. Did it require an email to sign up?
No, they implemented that at the point of the patient visit. So patient walks in the door and there's a conversation with them about it. So they didn't do, I see what you're saying. Did they have to actually get a validated email account in order to receive that? And yes, the answer was yes, you had to have a Gmail account. And what we found was that a number of people ended up getting help in setting up a Gmail account in order to do that. But then we also found a substantial minority of patients ended up using the whole portal on their phone anyway, and so we're doing all of their patient information management tasks on the phone. But yes, that is another barrier that typically as part of the registration or as part of the activation process, there's an email sent to your Gmail account. You have to click through and validate that that's you in order to access it.
And another question for you, Jessica, too, about whether you have any data regarding how long a patient stayed on a particular health information link that they clicked. So the question is trying to get at whether the patients actually spent time reading the information.
Yeah, that's a really good point. Sadly, with this particularly with the info button functionality that I talked about, if you were a patient and you clicked on it, it actually called up a pop-up window. It took you outside of our website. So we don't have any way of tracking once they've left our website and gone to Medline Plus. We don't know how long they spent reading it or if they read it at all. So the portal account window remained open, but this second pop-up window, we were not able to measure how long they spent on it. So it is possible some people just clicked and then dismissed it without reading it. I hope they spent some time reading it. That's a great point.
Thank you. And Courtney, here's a question for you about how you implemented the training. Can you provide some details on that?
Yeah, of course. We implemented the training, I've mentioned it briefly, but I'll give a little bit more detail, where we enrolled patients and they came in person and they either watched the videos with us and we answered questions about the portal as we went along, or they came in and we had to consent them because it's a research study, and then we gave them a brochure about the portal, which is the standard material that we give to any patient who signs up in our system, and we sent them home with the printed link and a few key screenshots about how to access the videos so that they would have a how-to to watch them on their own. That's how we implemented it. To Jessica's point earlier, we were really interested in how to scale this most broadly because in-person training is a very time-intensive and resource-intensive task, and so we were trying to get at within the study how much better we could do versus in-person versus just providing more training materials on a static website. And so that's what we'll be evaluating in the 6 months following training that we're just now completing the data collection on. And I just wanted to also, I know this was Jessica's question, echo this idea of email addresses. Because we need an email account to sign up for our portal as well, we only enrolled patients who had an email account because we felt like that was the right group of patients to start with. It's the right group of patients to train rather than teaching them how to use email off the bat. And that would be a slightly different type of digital literacy training that they needed. But probably a third of the patients in our study who came in and had an email account hadn't signed into it in 6 to 9 months in our patient population and needed refreshers and needed us to actually help them reset their password to the email. So it's a pretty big, it's a challenge among, these days and age, many people are not using email as much as they used to be, but especially among a more underserved patient population, I think it's something really important to think about.
Kind of a related question that came in is the fact that patients, doctors all use different types of portals that all work differently. So, if a patient is seeing multiple doctors, there might be even a challenge around that too with respect to portal access and being able to effectively use a portal. Have you encountered any of that? Does anyone on the panel want to comment on that?
This is Jessica, and yes, I did encounter that. I didn't present any of this, but we also did an in-depth interview study with patients, actually primarily here at Cornell, not necessarily at IFH, where we were looking broadly at how do patients currently manage their health information. So we didn't select only portal users. We actually did a sort of an all-comers recruitment from the primary care clinic. And we found that when you recruited that way, you found relatively few people who actually were using the portal, and the ones who did had become relatively savvy about the fact that some of their information was here, some of their information was in, I'm thinking of one guy who was a veteran, so he had some of his information at the VA account, and he knew that he had to export this report and get it, printed out and bring it over to his physician here because he knew that they didn't communicate. So we did recently publish a paper in the Journal of Medical Internet Research about these burdens that patients faced as they started dealing, especially patients with multiple chronic conditions who are seeing doctors in different medical systems and seeing their information fall through the cracks, seeing their lab results done at one place not getting delivered to another place on time, seeing, things that they need happen sort of fall through the cracks because of these lacks of interoperability, and recognizing that they were on the spot for trying to carry their own medical information back and forth, and it's really a burden if you're sick and have a lot of things wrong with you, that this is one more thing you need to worry about.
Would anybody else like to comment on that particular issue?
I fully agree. It can be a burden. I don't see it as much in our system since most of our patients are with us for both primary and specialty and hospital care in the same system. So the portal would serve them that. But when we go out in the community and try to, say, work with community groups who are already in senior centers or working on training programs for digital literacy capacity more generally, and even the public library system is interested in this topic to help offer support for people who walk in and want help with this, they are challenged by, they would have to know how to use all the portals that are available in the city and county of San Francisco or even broader to be able to actually help people be able to access all of them. And that's a real challenge, both on the patient side and for people trying to work with community-based groups on this issue.
I'm not sure if this is entirely related, but a question came through about the panel's thoughts on use of smartphones and apps to access portals. I don't know if that would help alleviate the problem with respect to accessing various types of portals if there were like a uniform smartphone, a phone access method or something. But in general, have you had any thoughts about smartphone access to portals?
Yeah,
we've thought right. Oh, go ahead.
Jessica. Okay, I'll go first. I'll go quick. just that we've thought about it a lot. And at Kaiser in Northern California, I know, for example, when they launched their app for KP.org, they only really got a 5 to 7% bump in total usage and not necessarily decreasing the racial ethnic differences that I showed. And so to me, that sort of speaks that you might be getting different patients, but you might not. You're already, if people are really engaged and want to use the system, they might have already figured out how to do it through a desktop or a computer version or the mobile browser on their phone. So they're still using it on their phone, but it's not through an app per se. And when we think about it in a safety net, it becomes a more primary means of device ownership for our patient population. But I would still say whether or not it's an app versus mobile browser, I don't think it's, even though many of our patients use smartphones, a lot of them actually aren't using very many apps. They're using some of the basic functionality on their smartphone. It depends on how old they are and a bunch of other characteristics. But I think it's important to mobile optimize the portal, which is not usually often done. But also to offer an app version, but to not expect that it's going to be the silver bullet.
Mm-hmm.
I'm really glad you said that. That's more or less what we found as well. So IFH did implement a mobile version, mobile app, and they, because of the very compelling data from the Pew Research Foundation and all sorts of other people showing that there's some disadvantaged patient groups are more likely to access the internet via their phone than by computer, and that many groups may progress directly to smartphone without ever actually using a computer. When they implemented it, they did get a small, a little dedicated group of people who were using the mobile app. But you are exactly right that it was not the kind of overwhelming response that they had kind of hoped for. So anecdotally, when I've been doing some of this interview work in the clinics, I actually have seen some of the more educated and affluent patients being the most enthusiastic users of the app, because these are the people who are already used to doing, for example, their banking on their phone. They're already used to using it for service purposes, so they're perfectly happy to also use their phone for this purpose. I do think there's room for improvement here, room for growth, that if we had, really usable phone apps, we could potentially reach more people. We also run into the, iPhone versus Android issues, that not everything is adaptable to both. We also then run into the smartphone version issues, which is I certainly talk to patients who are still using clamshell phones, flip phones, whatever you call them,
Right.
and a lot of patients who don't have any kind. And somebody who has an iPhone might have, 3 versions ago. So in practice, it starts to get trickier than in theory.
And one final question here before we close. Have you collected patient-reported outcomes through your patient portals? If so, which ones?
I'll address that. I actually, not so much in the data that was shown, but that's what my other project is. It's actually about focusing on collecting patient-reported outcomes using a mobile health application. But in our patient portal right now, we are not specifically doing that, but we are going to be expanding to do that, to using the Acute patient portal to be able to collect some more patient-reported outcomes.
Anybody else?
This is Jessica. I've just started working with Memorial Sloan Kettering Cancer Center on a patient-reported outcomes system for ambulatory cancer surgery to help patients self-report side effects and recovery from surgery. So they seem to have, to date, a small and relatively enthusiastic group of users, but we're just starting on this, so I really don't have that much.
So no concrete data yet. Well, thank you very much. We've reached the end of our time for this webinar. Thanks, everyone, for attending. For those interested in obtaining continuing education credit for participating in this webinar, please visit the URL shown on the slide that just appeared. You will select today's webinar, which will be indicated by date and title, and then complete a brief evaluation of the event to claim your credits. You'll have until May 4th to claim your credit for participating in this webinar. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation. We hope you'll complete this survey to share your feedback with us. And once again, thank you all very much for participating. We hope you'll join us for future learning opportunities.